91.9. That sure will take you back a little bit. Back to the mid-80s. It's called Addicted to Love. Robert Palmer. So here's something. Dr. Steve, here's something that you didn't know. Did you know that Robert Palmer was in a band in the 70s called Vinegar Joe?
I did not know that.
You did not know that. It was so this song was originally he chose at the end of the day. He wanted a duet with us, with Chaka Khan.
I did not know that either.
And she said, no thanks. I'd rather not.
Well, there you go.
See, I'm full of interesting fun facts like that. So it's a very good afternoon. If you have just tuned in, welcome to Medical Mondays, brought to you by First Care Solutions. Today, pulling back the curtain on what really goes down inside the emergency units. Forget Grey's Anatomy and all that other nonsense. This is the reality check, and we've had quite a few messages coming in on the WhatsApp line going, we're really looking forward to this. So shall we jump right in, Dr. Steve Holt?
Let's go for it.
Right, our first question, why do we sometimes wait so long in an emergency unit?
So it's a great question, and it's actually a very interesting answer. So obviously with emergency departments, the patient arrival time is completely variable.
Yes.
Nothing is booked. So what usually happens is there are certain times that are busy, and we can accommodate by being aware of that and having more doctors and more nurses on duty to make sure that things flow. But there's a lot more to emergency medicine than that. And one of the biggest things is acuity. So how sick people are.
Okay.
And people arrive in dribs and drabs. Suddenly there's an ambulance. Then there's 2 or 3 really sick people at the same time. And what tends to happen and make people grumpy is that they get bumped down the queue based on the fact that there are sicker patients ahead of them.
Yes.
And we have all sorts of ways of trying to mitigate that in terms of opening up additional beds, getting in more resources, trying to streamline the triage process to get sicker patients through quicker. But it's a complex sort of algorithm, if you like.
100%. In terms of, you just mentioned triage now. Who decides, or how do doctors and nurses decide who gets seen first?
So there's different types of triage. In South Africa, we use the South African Triage Score, and that is a methodology that measures your physiological parameters and then has a number of items that can sort of upgrade you or downgrade you based on whether you're actively bleeding or actively have chest pain or actively have certain other things. And generally speaking, we then apply a color-coded score to assess who we see first. And that's specifically to make sure that we don't miss people who are genuinely sick, who are so sick that they can't speak for themselves. And that's it's a common philosophy that the louder you are, the sooner you'll be seen. That's not the case. The object of scoring that triage enables is something that allows us to see the right people first.
So, I mean, I've seen it firsthand because having experienced it. It's you guys do the sats and you do blood pressure. I mean, and obviously you do a once over. Now these are what I would commonly refer to as the basics, right? These are the things going, okay, you're okay, you're not okay, we need to see you now. So whether it's red or orange or yellow or green, those are the things, according to the list the triage list that you're now talking about, how people can jump the queue. Is there such a thing?
No, I mean, you can't jump the queue. If there's not a lot of people, you may be seen in the order that you arrive. If there's a lot of people or you have a lot of particularly sick patients, then definitely you will be sort of bumped down the queue. But very often what happens in an emergency department, particularly the bigger ones, we have different types of doctors on duty. So you may have a doctor that's seeing just the minors, and then you'll have a cohort that are seeing the more severe cases. And as a result of that, sometimes it's very quick and you can get through all the green or yellow patients quite quickly, and then the other doctors are dealing with the major cases. The challenge comes in when you've got these very small emergency units that are often in the more peripheral towns, and then you end up with a situation where there's maybe only one doctor on duty, and one comes in if you have extra sort of surge that happens in the unit, and that takes a little bit of time. But unfortunately, there are other things that dictate waiting time, the actual physical resources. Sometimes if you get 10 patients into the unit at the same time, that fills up all the beds in most emergency departments immediately. You haven't got anywhere else to put people.
Yeah.
So the sort of art of managing patient flow comes into how you can distribute patients to the laboratory, to the wards, to X-ray, to the coffee shop if you need to, just to try and keep the flow going.
Yes.
And of course, communication is the most important
key,
thing.
yes. So let me hit you with a scenario here, and this will lead into my next question. One room available. Let's call it one. What would you call it? One bed available.
Yeah, one bed available.
2 patients. Both of them can't breathe. Both of their oxygen is in the 80s, and they've got, let's call it, high blood pressure. How do you choose? And what is misunderstood about these kinds of visits to the ER?
So again, there's 2 types of triage. If your resources are overwhelmed, then you need to treat the person who has the best chance of survival first. If your resources are not overwhelmed, then you treat the sickest patient first. And that is a subtle difference.
Yeah.
If you can imagine a bus accident and there's 20 or 30 people that are all badly injured.
Yeah.
Your resources are completely overwhelmed.
Exhausted, yes.
You cannot cope with anything more. You then treat the people with the best chance of survival first, as opposed to those who may have very severe injuries, who have very little chance of survival, and then you would not treat those. That's a kind of military scenario.
Okay.
But in the emergency units where we'll gather extra resources, we'll try and find additional beds in the hospital.
Okay. So it's not like all is lost.
No, definitely not. I mean, never. It's never a situation where all is lost. Well, never.
We're going to take a little music break in just a little bit, but I just want to touch on this. Something that I've heard, it's quite a common theme. Why does the paperwork, the discharge, or the signing up, if you want to call it that, why does that take so long, and why is it so important?
Yeah, so firstly, it's important because we need to know who you are and what you're about, and whether or not you consent to having the treatment done. We also need to know, obviously, about any medical history in the past, and you also have to know about your financial situation. We have to make you fully informed of all of that, and we need to make sure that you understand what treatment you're going to have. So there is that process. Often also in emergency departments in South Africa, it's managed by a few different entities. So every medical practice, the emergency included, requires their own consent, their own terms and conditions, their own set of rules that are required. That only really applies to the not so sick patients. If you are life or limb threatening, you'll be treated immediately without one document.
Wow. Okay. So I've heard people talk about that. It's a whether you have money or whether you don't, or whatever the case may be. It's always ERs they will not let you go. I mean, if you've signed for treatment, it's always about stabilizing the patient first, right?
So we will always make sure that a person is properly assessed, whether they have money or not. That's irrelevant. Once we've assessed them, then you give people the opportunity, in trying to explain to people that there are options.
Yes.
So you're welcome. We know that you are stable. You're not going to deteriorate.
Yeah.
We're not putting your life or your limbs at risk in this particular process. What would you like to do now?
Yes.
We can admit you here. We can do this now. We can do that, and then do it as an outpatient. We can send you to a government facility. We can do all different things.
Okay, so there's options.
Yeah, and that takes a lot of time.
Okay. When we come back, we're going to chat a little about some of the toughest moments we've all had. Well, not me, but As a patient, yes. But we'll do that on the other side of these. If you have just tuned in, it's a very good afternoon. If you have any questions for Dr. Steve, Dr. Steve Holt, 084-221-2919. If you have any questions about the emergency room, and if we have a little bit of time, we'll get to all of that in just a bit.
Positive music. Positive people.
Let's do it.
91919.
Lenny Kravitz, I saw this dude. It was actually my very first concert I ever went to.
That's
Back
pretty
in
cool.
1999. And he did his whole thing. He was then it was called the Sun Dome. And we went and we watched him in 1999. And went off stage. And everybody chanted one more, and he came out. And his encore was Black Betty.
Ah,
I was like, and having been as young as I was then, you were kind of young to appreciate that. But looking back on that now, you're like, wait, what a moment.
very cool, very cool.
Medical Mondays powered by First Care Solutions, chatting about the ER and everything that goes on. Dr. Steve, how do you handle patients that are like rude and aggressive and like demand to be seen first, etc.?
Yeah, it's a difficult one. That sometimes you do, sometimes you don't do it particularly well. We try and teach our doctors to de-escalate things as best they can,
Yeah.
and try and get people into, getting them what they need
Yes.
without being drawn into things that they don't need or that are getting in the way of
Yeah.
either their treatment or the treatment of their child or the treatment of other patients. So it is a complex thing. It's something that you get better with experience.
Okay.
But trying to keep your own blood pressure down
In
on
check, yeah.
can be a challenge.
Okay.
People say a lot of stuff. They're often intoxicated.
Yeah.
Drugs or alcohol are common in the emergency unit. So people tend to be. Sometimes it's not aggressive. Sometimes it's
Desperation?
desperation, belligerent. Just not nice personalities. But it's part of the job, and you get
Yeah.
used to it. One thing that's very important is that head injuries can mimic, strange behavior.
Okay.
And especially if someone's been drinking and then has an accident or gets hit on the head or something, deciding whether it's the alcohol that's talking or whether it's the head injury that's talking is very important.
Okay.
And as the medical practitioner on duty, you've got to make damn sure that you don't label people
Yes.
as being,
Aggressive.
just drunk.
Yeah. To do full assessment, I suppose you would need to. If you were happy to share some of your toughest moments while trying to keep your cool.
I think a lot of it is often with parents.
Yeah.
Parents are very concerned, rightfully so, and they want the best. But sometimes, there needs to be either full investigation done, and by
True.
investigation, I mean you need to look at not just the things that they think
Yeah.
it is, even if that appears quite obvious.
Yes.
There can be other challenges
Okay.
that are sort of hidden. So trying to stay focused on the patient as
Yeah.
opposed to the parent or partner that can be quite interfering is very difficult.
I suppose it's always quite volatile, especially with kids, right?
Yeah. Look, emergency medicine is a volatile place. It's why most complaints originate out of the emergency department. And in a sort of a calm day, a person may be completely normal.
Sure.
Under stress, people behave differently. And that puts a lot of pressure on the doctors. It takes a real toll, not just the doctors, the nurses and everyone else in there. And if you're dealing with the patient before may have died or may have had a significant injury or something that's really sort of drained you emotionally, and then you're moving on to someone who's there for a sort of sprained ankle, who's belligerent and wants to get back on the field, and so you have to manage your emotions quite quite strongly.
I suppose it's a big jump, as you said. Like you're seeing a variety of patients, a variety of personalities. I suppose it takes something really special to jump from let's call it worst case scenario, let's call it death, to a sprained ankle, to somebody who needs to needs to have some medicine for their chest.
Yeah.
I suppose it's and if each person is not a nice person, I suppose that's consistency, I guess.
No, it's not about that. It's about, we all have a personality. So I may get on with a particular type of person, and I may be able to get a rapport going with them very quickly and very easily. Others, I may not. There may be a language barrier. There may be something they've done that I don't particularly agree with,
Yeah,
or something
sure.
like that. So you're constantly trying to build a rapport, even though the circumstances are not to your particular
Yes.
personality or liking. And the same for the patient. You know, they may like a particular type of doctor. Some want to see a male doctor, some want to see a female doctor, different races, different languages.
Sure.
And often something is said that gets things off on the wrong foot.
Sure.
And that's where we teach our doctors to try and de-escalate that as
Yeah.
quickly as possible.
Okay. What advice would you give patients to make their ER visit a little smoother?
Sure, try and trust the system, and I know that's difficult, and certainly the way that emergency departments are set up are quite different from between different hospital groups and different physical locations. You know, some are old, some are new, some are built better, some have, you know, different flows, and it also depends with what you're there with. But I think if firstly you can be prepared and know what you're going to expect. We are constantly trying to evolve the patient journey and make sure that that patient journey is improved, that there's good communication, bearing in mind that there are some sort of statutory things. We have to get all your information, we have to get your permission, we have to...
It's a lot.
all of that stuff takes time. And when you're standing there, you know, in pain or upset or something, or just feeling terrible, that feels like
It feels like an emergency.
exactly.
Shame.
So bring your ID, bring your
Come as prepared as
medical
possible.
aid, come as prepared as possible. And if you really think if it's a non-emergency, you're in an emergency unit.
Yeah.
Okay, so understand that there may be other people there with a real emergency. So getting to the airport on time may be an emergency to you, but it's not
But
to us.
it's not to the Uber driver.
Yeah.
Absolutely. How would you recommend, let's talk about you for a second. How do you personally cope with the sort of stress of the back-to-back emergencies?
Again, I think it's experience, making
Okay.
sure that I'm well rested. You know, if I've had a terrible night, or I've been out late, or I've been, I'm tired, then my ability to cope is less.
Okay.
So if I do go on a shift, then I prepare myself.
Yeah.
I make sure that I'm there on time. I'm not rushed. It's like arriving at the golf tee. You know, 3 minutes before tee off.
That is such a good description.
You want to get there. You want to be calm. You want to make sure that your day is taken care of, so you can be present. And I think that's one big problem that doctors tend not to do. They tend to arrive there with, you know, there's a plumbing issue at home, and they're
They're not leaving it at the door.
They don't leave it at the door, and that's difficult if you're rushing, tired, all of those kinds of things.
I think if I speak for the general human being, I think, and as you said, and you put it quite nicely, is that your emergency is not somebody else's emergency. And it's quite hard to leave that stuff at the door. You know, like when you're emotionally invested in a family, or your family at home, or as in your dog has died. You know, these things are hard. You know, it's easy for you and I to say, just leave it at the door. It's hard, but to be good at your job, you've got to be able to do that, I suppose, at the end of the day.
Yeah, you have to, just like you have to turn up here and have a smile in your voice and be able to chat to everyone.
Yeah.
We have to be able to do the same, and it is difficult at times. And for me personally, if I am tired, my sort of
Tolerance
emotional
level.
threshold is just not there.
Okay.
So trying not to be tired when I start is the biggest thing.
Okay. Our last question: what's one small thing patients could do that would help your staff out a lot, other than being prepared?
So I think understanding the system is a good thing. So do your research. You know, make sure you know where you're going if you do have an emergency. If you don't know where you're going, or you can't know where you're going because you're in a new place or whatever, then try and understand and ask questions. Try and be certainly for us, it's very easy to ask questions. No question's a stupid question, you know. But a lot of people complain after the fact and say, I was never told this, I was never given that. And if you're not sure, then ask.
Yeah.
You know, and also if you in the car park leaving and you're not happy, come back, talk to someone, let us help you. There's no one, we're not trying to not help you. But I think certain circumstances, again, you know, you can imagine the doctor who's got, you know, multiple patients to see at a time. He's jumping from patient to patient to try and get this one to x-ray, that one's blood results back, this one counseling, that one needs some treatment, this one just needs to get to the airport, that one needs a script, this mother is crying because it's actually from something's happened to the kid at school. So you've got all this juggling that goes on, and that is probably the best asset for a doctor to be able to manage multiple patients, is to be able to keep calm and focus per patient. But I think patients need to take some element of responsibility for themselves, not of the treatment, but to understand what is going on and ask the question and give us information. Tell her we don't know stuff we don't know.
So I wanted to ask something. I noticed that you've covered this beautifully. Now, for somebody like me who has a challenge with mental health on occasions, sometimes my wife says to me I'm not, but sometimes she tells me I'm just crazy. What do you do if somebody walks into your ER that is having, let's say, their multiple personality disorder, or they're schizophrenic, and all that they need is something, the medication for whatever's going on in their head? Like, there's no actual physical injury, it's more of a mental thing.
So those kinds of cases are particularly challenging because we have to assume, because of the person's mental illness, that they may have something else going on. So it's not a case of what you see is what you get always.
Sure.
So that type of person often, they can be immediately triaged, they can be taken to a quiet place, they can try and give them some sort of personalized intervention, leave someone with them the whole time, and then try and understand the problem to be able to give them that medication. But it doesn't mean that you don't then follow the process in order to make sure that something is not missed. Because missed things in an emergency department, because it's emotional, because it's fast-paced, because
it's easy to make mistakes.
It's very, very easy to make mistakes. And if I have one request of the public, is to be a little bit understanding.
Absolutely.
Can you picture that sort of Friday evening? There's some drunk people in the room. There's things are going on. There's a bit of trauma. There's a bit of
chaos.
this, a bit of this. It's organized chaos, and then someone's yakking in your ear. I need this. I just need to get there. I just need to leave. I just need this. I just need that. And the thing that is being presented, the sore tummy today may not be an appendicitis right now. Might just be a sore tummy, a gastro. Tomorrow, when they go to the GP again because they're not better, and the GP says, "Oh my God, this is it's obviously an appendicitis." The earlier presentations are sometimes very difficult to differentiate, and in that environment, it's even more difficult. So I think that understanding is, if you get seen, if you come back to us within 24 hours with the same sort of problem, things are not getting better, we'll help you. It won't cost you a cent.
Yes. If people want to chat to you guys, and if people want to have a look at what First Care Solutions and Care First are doing, where can we find you guys?
So any number of our websites, from an emergency medicine perspective, the ER Consulting website has got quite a lot of useful information on it and who to speak to and how to get there. That's www.erconsulting.ca.za. Care First is our virtual healthcare platform. www.carefirst.co.za, and our training platform is AIEM, AIEM, www.AIEM, the Africa Institute of Emergency Medicine. That's also really useful. If you want to be more comfortable in an emergency, go and do a first aid course, do a CPR course, make sure you know what to do.
Absolutely. Dr. Steve Holt, as always, thank you so much for your time. If you have, so we're going to do some questions next week, right?
Yeah.
So what we'd like to do, we'd like to encourage you, if you have questions about anything that is trauma, medicine, anything medical related, and you have questions, you can send us a message on 08422129119. Alternatively, if you'd like to keep it a little more professional, a little more private, you could pop me a mail at paul@919.co.za, and we'll get to as many of those questions as we can next week. Doctor, thank you so much for your time.
Pleasure, Paul. Nice to be here.
Same place, same time, next week.
See you then.
Need trusted insight into the future of healthcare? Join us every Monday at 1:15 p.m. for Medical Mondays on 91.9 FM. Brought to you by First Care Solutions. we unpack real issues with real experts. From virtual consultations to the innovations redefining patient care in South Africa. Stay informed, stay empowered. Visit www.firstcare.solutions for more. First Care Solutions, putting healthcare first.